So we are very thankful again for Per Andrèn for presenting the webinar today. He is a clinical psychologist and PhD student from Stockholm, Sweden, from where he joins us again this morning. His thesis is on behavior therapy for Tourette's, specifically for internet-delivered treatment and primarily ERP. And he is also one of many authors of the recently updated European Clinical Treatment Guidelines for Tourette's. Thank you, Per.
Thank you very much, Julian, for that lovely presentation. Let's move on. We have around 50 minutes of presentation, then 10 minutes for questions. And obviously this is part 2, so it's the sequel to part 1. So we will have a quick, brief summary here of what we did in this. You already know, the slides will be available. What we will talk about today is obviously part 2 out of 2, and then perhaps not directly related to the ERP itself, we will also talk about functional analysis and interventions, which may be applied to, I mean, it could be used as a standalone intervention for tic disorders, or it could be applied in combination with habit reversal training, HRT, or exposure and response prevention, ERP. But I thought it would be it would fit here to talk a little bit about that as well, to get the full pictures and then the questions, of course. A little summary of part 1. Tics are common and often impairing. I mean, I presented a little bit of background about tics and tic disorders. Tics are usually preceded by unpleasant premonitory urges, and we talked some about these urges and how they relate to the exposure and response prevention. Psychoeducation should be provided to every patient that is diagnosed as like the basic intervention to everyone. And then there are several evidence-based treatment options such as HRT, ERP, and medication. And then we talked primarily about ERP, and ERP stands for exposure and response prevention, and the exposure is to the premonitory urges, and the response prevention is another word for more or less suppressing the tics. So that was part 1. And today I would like to start with just providing a little bit more detail of how a session could look like, and how a full treatment could be divided into sessions, and what preferably could be done during each session. So give it a little bit more practical and a little bit more usable information, hopefully. So I think I already touched on this previously, and it was also in one of the questions. Sessions should mainly be devoted to practicing ERP with support of the therapist. So not so much talking about other stuff, but try to get as much time to actually use the ERP strategies with the therapist support during these sessions. And here are a few suggestions for homework. We usually divide it into 2 various categories for the patient. Just for it's good for memory. It's pretty clear. And one is exercise at home, and that is to practice ERP in various situations, especially situations where the premonitory urges and tics usually appear. And there's no rule that it has to be done the certain amount of minutes each day, but we say something around 15 to 30 minutes. We need to tell the patient something at least. I mean, in the end, we want them to practice as much as possible, so more or less practicing all the time. But you can't really say that to a patient, especially not a younger patient. So you need to start with something and then get used to using these strategies. And then we also want to exercise in other places. Could be a weekly assignment. I mean, also there it could be good to exercise like all the time in any place, but especially a child will not really remember that. It will be an overwhelming exercise. So then as a memory aid, just pick a few sessions, like 1 situation or 2 situations where the patient know, okay, when I'm in this situation, I'm going to practice my ERP. For example, when the patient is on the bus. The goal is to gradually expand the ERP practice to more situations so that suppressing tics becomes more automated and part of the patient's everyday life, kind of like I was describing just a minute ago. But also important to remember that no one can really force the patient to practice ERP. It is of course up to the patient him herself if they want to suppress the tics in a given situation. So I mean, always do this in collaboration with the patient, decide on the plan and work from that plan. Here is an example of how the session, the treatment could be divided into sessions. And I think I based this primarily on one of the manuals. I will show the manuals again in the final slide today. But it might also be mixed up a little bit with my clinical experience. I mean, this is a naturalistic environment. You don't need to follow a protocol super strictly, but you should be aware of how you potentially could use the manual and then how you could present and divide the various strategies into sessions. So session 1 here, start with psychoeducation. Suggesting to write a list of the current tics could be good for the child to be aware of, or the patient to be aware of the current tics, but also for you as a therapist to be aware of them. It's like a memory aid for the two of you. Provide the ERP rationale as I've described during part 1, and begin already, if possible, with the response prevention. Usually the psychoeducation for tic disorders doesn't take that long, so you can usually get started pretty early with get to the chase and quite quickly and just start with practicing response prevention. If you're working with children, perhaps a reward chart could be something to use as an extra motivator during the treatment. And the homework to session 2 could potentially be using a tics diary, like writing down which tics they've had in various situations. Obviously not all of them, but recurring tics in recurring situations. And to practice response prevention for at least 50 minutes daily. Session 2, potentially formulate some goals. It's perhaps not always needed when treating tic disorders can be difficult. It's not like patients often avoid situations, kind of like in OCD or in an anxiety disorder. So it could be difficult to find goals that are actually easy to measure and follow, but you could potentially find, we don't want goals like just be better at suppressing tics because that is so very hard to measure. But you might find something in a dialogue with the patient and the family, that something which is actually measurable and that could be used as a goal during treatment. Then obviously response prevention, use a stopwatch, record the times, write down the times on perhaps a high score list or something like that. And then you can start also with the function analysis and interventions. And I will talk more about that in the end of today's session. And then homework, using response prevention for at least 50 minutes daily. So it's kind of similar to the previous homework. Session 3, then we want to move on a little bit to the exposure part of the ERP. So to define and identify the premonitor urges. The patient gets to estimate the severity of the premonitor urges, and then also add exposure to response prevention, and that could be focusing on the premonitor urges and where they are felt in the body. That's kind of the first exposure that is described in the treatment manual. Homework, potentially practice the ERP with intensity ratings of the premonitor urges and do that for at least 50 minutes daily. Session 4 and onwards will be more a repetition of the same things. So potentially, I talked about the potential of using exposure hierarchy, like this ladder. I showed it last time. I said it was, I mean, you don't need, it might fit some people, it might not fit other people, but it could be used. And you can then practice ERP based on these steps and gradually make the practice more difficult. And then you could focus the ERP on practicing ERP, the homework on practicing ERP in various situations for at least 50 minutes daily. And then, as I said on the previous slide, also suppress tics outside of the a priori plans. No, sorry, that was something else. So we kind of obviously want them to practice ERP at home, but we also want them to practice ERP based on these situations they've listed in the exposure hierarchy. So they also get, it could be like practicing on the bus or practicing in school on a first lesson each day in school or something like that. But then also, I mean, what you want to add gradually here is suppressing tics even outside of the a priori planned situations for generalization purposes. So we in the end, we don't just want them to use these strategies when the therapist has said that they're going to practice. We want them to use it, generalize this, what they've learned, and use it all through the day, kind of automate. Last session, obviously, go through the tics diary. Then you can compare which tics did you have when you came, and then which ones do you have now. Follow up on the goals. Do a relapse prevention plan, how they're going to continue practice, and what to do if the tics come back and are worse again. And you can think about if you want to have a plan that will enable booster sessions later on, and also it could be good to actually have a proper follow-up later, kind of like a 3-month follow-up or a 6-month follow-up or something like that after the end of treatment. Since I think we talked about this last session as well, that tics wax and wane naturally, and it could be that they've actually just waned when you end your treatment, and then the tics will be back quite thoroughly just, I don't know, like a month later or so, and then they're in need of treatment again. So it could be good to have some to enable the possibility to have booster sessions, so the patient doesn't need to like seek help again from the beginning and getting assessed again, getting assigned a therapist, and so to leave it a little bit open if possible. Now we're moving on to a demonstration, a film demonstrating ERP. And what you will see in this film is roughly 8 minutes. You will see a therapist to the right, and then to the left, you will see a young patient, Kim, played by an adult therapist, and her mother, also played by an adult therapist. And this is in Swedish now, so you will get to hear a little bit of my language, but it's subtitled. And this was filmed during lockdown, my colleagues will look a little bit funny, you're wearing visors, but I think you get the reason for it. And if we have some technical issues now, you will get the slides. You can just enter this link here, and then you can look at this again. So let's see if this flows now or not. Otherwise, you can watch this afterwards.
Välkomna till den här demonstrationsfilmen där vi ska visa upp hur man kan öva på ERP under sessionen. Och det kommer jag göra tillsammans med Kim, 9 år, och mamma Maria här. Och det här är ganska tidigt i behandlingen. Kim har fått börja öva på att stoppa sina tics lite. Nu ska vi öka svårighetsgraden genom att jag kommer att fråga om Kims varningssignaler också. Och varningssignaler, det är det ordet vi använder för försändningar. Eftersom Kim är 9 passar det bättre att använda det ordet istället. Yes, så vi sätter igång. Ja, nu Kim. Nu är tanken att du, precis som vi har gjort förut, ska försöka stoppa alla dina tics samtidigt. Och då är det precis som förut, då är det alla tics på en gång.
Ja, men det är jättesvårt.
Det är jättesvårt, men jag vet ju att du har klarat det förut, eller hur?
Ja, men alltså, sen efteråt så var jag alldeles tokig, eller hur mamma?
Ja.
Sprang omkring i hela huset och skrek.
Gjorde du? För att det var så jobbigt? Oj, oj, oj. Ja. Det kan vara så. Du vet, när man tränar på att stoppa ticsen, att det tar ganska mycket energi så här i början. Precis som annan träning. Om man ska lyfta en jättetung sån här vikt och så har man inte tränat så mycket. Om man skulle försöka lyfta 50 kilo första gången, då skulle det vara jättetungt. Och då kan man ju bli jättetrött efteråt. Så det kan vara lite samma med ticsträning.
Ja, det var precis så det kändes.
Det var så det kändes, ja. Men det är ju också så med ticsträning, precis som med annan träning, att ju mer man tränar, desto starkare blir man. Och i det här fallet med tickträning, då är det ju järnbromsarna som blir starka. Kommer du ihåg det? Det är de som hjälper en att stoppa
Jag
ticsen.
kommer ihåg, jag ska dra åt dem.
Jajamän, du ska dra åt järnbromsarna och försöka stoppa alla tics.
Jag lovar.
Och eftersom vi har tränat lite på det här tidigare och jag vet att du har klarat av det här, så tänker jag att vi ska göra det lite svårare idag också. I början kan man känna sådär, nej jag vill inte. Men jag tror att du kommer klara det också. Och det vi kommer göra, det är att jag kommer fråga om de här varningssignalerna. Kommer du ihåg dem? De här små som känns i kroppen innan ticsen kommer.
Benen.
För dig sitter det i benen. Hur är det du brukar kännas i benen då?
Det känns liksom som att det kliar i benen.
Det kliar i benen.
Och sen nästan som att det är sån här, vad heter såna? Vad heter de?
Myrorna?
Ja, precis.
Ja.
Myror som liksom går inuti benen och biter mig.
Precis så brukar faktiskt många barn som jag träffar säga. Det känns som små myror som killar en. Och så är det för dig också.
Ja, jag känner dem nästan nu bara vi pratar om det.
Precis så brukar det vara när man pratar om dem, att då känns de lite extra starka. Och då vet jag också att när man gör sådär, när man frågar om varningssignalerna, då kan det bli lite ännu svårare att stoppa ticsen ibland. Och då kan man ju undra, varför gör vi det då? Varför ska vi fråga om varningssignalerna om det blir svårare? Ja.
Det blir starkare.
Exakt. Då blir järnbromsarna extra starka när träningen är svår. Eller hur?
Ja.
Så nu ska vi låta järnbromsarna träna riktigt hårt idag.
Okay.
Och precis som tidigare så ska vi ta tid. Och så kommer vi skriva upp rekordtiderna på tavlan. Och sen så när det kommer ett tics, då stoppar vi tiden. Och då hjälps vi åt allihopa och se när det kommer ett tics. Precis som förut.
Men kan vi vänta tills jag är redo?
Vi kan bestämma tillsammans när vi startar klockan, så kan du få förbereda dig lite.
Ja.
Så att det inte kommer helt pang på. Så. Och då kommer jag under tiden också fråga som sagt om hur det känns i kroppen med varningssignalerna. Och så kommer jag ibland be dig berätta för mig hur jobbig den här varningssignalen känns. Och då kommer vi använda en skala från 0 till 10. Där 0 är att den inte alls är jobbig. Och 10 det är så jobbigt det kan bli.
Då är det liksom myrstackar i benen.
Exakt, då är det myrstackar i båda benen.
Usch, det kommer väl inte bli 10 eller?
Vi får se, det vet vi ju inte innan.
Nej.
Vi testar och provar och så se. Och det här är precis som annat. Vi provar en gång först och sen så ju mer man tränar, desto bättre brukar det gå.
Och om det är 10, då tränar du bromsen extra mycket ju.
Ja, det är sant.
Exakt.
Uff.
Jag vet att du klarar.
Okej. Ska vi börja med, om vi nu... Hur känns det mellan 0 till 10 just nu då i benen, skulle du säga?
Vad är skillnaden mellan 4 och 5?
Det kan ju du bestämma själv egentligen. Det finns ingen sån jättetydlig skillnad.
Nej, det är 4,42.
Ja, 4,42 är det just nu. Då kan vi skriva upp det här också. 4,42 när vi börjar. Känner du dig redo?
Vänta, jag ska räkna till 3.
Räkna till 3. Så kan du få trycka och starta.
Vad får jag sätta?
Då kör vi. Då är vi igång med tics-träningen. Och järnbromsen, är den på?
Den är på.
Du har satt i den. Jättebra, jättebra. Och då tänkte jag höra lite. Där, vet du vad? Där tror jag att jag såg en tics komma.
Nej!
Ögonblickligen. Men du klarade ändå. Ser du hur mycket det är?
Nästan 20 sekunder.
Nästan
Förra
20
gången klarade jag 35.
Ja, men den här gången så frågade jag om varningssignalerna innan också, eller hur? Så
Men
nu
jag
har vi
ska
gjort
klara
det lite
35 den här
svårare.
gången
Nu har vi
också.
gjort det lite svårare. Okej. Då skriver vi upp tiden här och så kör vi igen. Så får du sätta igång klockan igen.
Är du redo, mamma?
Jag är redo.
Okej. Säg till om du ser det, tics.
Jag lovar.
Jo, den är igång. Nu är klockan igång igen. Och då undrar jag så här. Hur känns det i benen just nu? Kan du berätta lite igen hur det känns?
Det känns inga myrstackar, men
Nej.
det känns att de börjar liksom komma härifrån och på väg mot knäna.
De kryper mot knäna,
Ja.
de små myrorna.
Så kanske typ 3.
En 3 just nu är vi på. Okej. Finns det någon varningssignal som känns någon annanstans i kroppen just nu då?
Det känns att jag vill rycka med axeln.
Du vill rycka med axeln. Hur känns det? Känns det någonting i axeln då?
Alltså det är konstigt. Det känns faktiskt lite i benen av det med. Men det känns också här.
Ja.
I den här muskeln. Att det är nästan som ont på något sätt i den.
Det är nästan ont. Det låter lite jobbigt att det är så.
Får man hålla så här eller är det fusk?
I början så kan man testa sig fram lite vad man tycker fungerar. Men jag tänker att vi ska få prova, se och göra utan. Och där, vet du vad? Nu såg jag en liten näsrynkning som kom där. Så vi stoppar.
Över en minut.
Det är mitt rekord!
Nytt rekord! Snyggt jobbat Kim! Och det var trots att vi pratade om varningssignalerna.
Det var jättesvårt.
Jag såg på dig att det var jättesvårt. Det syntes att det var jättesvårt och ändå så kämpade du på och höll i där.
Då måste du berätta det för min lärare sen.
Det ska jag göra.
Superbra jobbat Kim.
Och det var jättesvårt.
Ja, det var jättesvårt och ändå så gjorde det. Snyggt.
All right, we
Välkommen.
thank the ladies for this presentation. Let's move on. So moving on to a few tips here. Try to make the practice as varied as possible. Encourage the patients to practice in a variety of situations, both at home and elsewhere. And again, we're talking about the generalization here. And kind of like with other exposures, of anxiety, it's important to practice regularly to have an effect. So the patient should preferably practice for at least 50 minutes daily. I think we've been through this already. And eventually the patient can be encouraged to suppress the tics in as many situations as possible during the day. So again, the generalization. So we want to get the practice into everyday life. One way could be to make a rule like always suppressing the tics at breakfast or in the shower, in the bus, on the way to work, first lesson at school, etc. But most importantly, make the practice fun, especially with younger kids, which might not have like as much inner motivations to do the practice as perhaps the parents or other people in the family may have, or adults have. So here are some tips for children first. Here it could be how to make it more fun and motivating. One way could be to make the ERP practice a game, kind of like a fun activity together with the family. Play hide and seek while suppressing tics, or follow the leader, musical chairs, etc. And do that with tic-like movements. It might be more difficult if some of the game also involves tic-like movements. We will see a short demonstration of this very soon. Tic bingo, draw note, use the tic-free zones. Like when I'm in this zone, in this room, I should always try to suppress my tics. It's always good to schedule the practice, especially with younger patients, so there's not a constant discussion between parents and the children about whether they should practice or not. So it's good to have that set out. Use a reward chart if needed. And it's good also that parents avoid nagging about practicing. I mean, it's good to have a clear argument on when and how the parent should remind, kind of attaches to the schedule, the whole schedule thing. And if possible, suitable, you could ask for help from the child's teachers, coaches, grandparents, etc. They could also remind about practice or something like that. But it's important to remind and not nag, and I will talk a little bit more about that later, because we don't want to just comment on the tics or negatively comment on the tics. It should be, if there are any comments, it should be related to the treatment, and it should be comments about something that like reminding about a strategy that the child has learned and can actually use. So there's a function about it. Moving on now to film 2, same thing there. You will recognize the people. There will be one therapist to the right, and then the Kim and her mother to the left. And if you want to watch this video again, you can do it via this link. And this one is 4 minutes.
Välkomna till demonstration nummer 2, där vi ska visa hur ERP kan gå till, hur man kan träna på det under en session. Jag har fortfarande med mig Kim, 9 år, och mamma Maria. Och nu har vi kommit lite längre in i behandlingen och har börjat öva på lite svårare saker. Så tanken idag är att Kim kommer få öva på att stoppa alla sina tics samtidigt som vi gör leken gör si, gör så. Och det här är då en lek där vi tänker oss att det är rätt svårt kognitivt. Man behöver tänka till ganska mycket och det gör det ofta svårare att stoppa ticsen. Samtidigt som man växlar aktiviteter och dessutom kan man göra rörelser som är lite liknar tics. Det brukar kunna göra det ganska svårt. Så det ska vi testa nu. Ja, hej Kim!
Hej.
Nu har ju du tränat på det här med att stoppa tics ganska länge, eller hur?
Mm.
Och jag vet ju att dina hjärnbromsar har blivit rätt så starka.
Ja, de är jättestarka nu. För min fröken säger att hon inte ser några tics alls i skolan. Och igår på hästridningen så hade jag bara tics när jag ryktade.
Är det sant?
Mm.
Det är ju helt fantastiskt. Superbra. Vad häftigt. Ja. Så nu har hjärnbromsarna verkligen vuxit. Och då, för att vi ska fortsätta träna hjärnbromsarna när de blir så här stora och starka, då behöver vi göra träningen extra svår. Eller hur?
Jo, jag vet.
Ja.
Men det är lite... Ja.
Och det har vi ju gjort hela tiden. Vi har gjort den svårare och svårare och de har vuxit och du har tränat. Så nu har vi kommit till ett riktigt svårt steg. Och det ska vi ju träna på för att jag också tror att du är redo för det. Eller hur?
Ja.
Och idag ska vi träna på det här med att stoppa ticsen samtidigt som vi leker gör si, gör så.
Mm.
Och varje gång jag gör en rörelse och säger gör si, då ska du göra... Nej, nu säger jag fel. Varje gång jag gör en rörelse och säger gör så, då ska du också göra det. Men om jag säger gör si, då ska du inte göra det. Eller hur?
Gör så ska jag göra. Gör si, då får jag inte göra rörelsen. Vad ska jag göra? Då ska jag bara stå stilla?
Ska du bara stå stilla?
Okej.
Och samtidigt försöka stoppa ticsen.
Just det, för man ska ju stoppa ticsen hela tiden. Glömde jag nästan.
Ja, det kan vara lätt att glömma det när det är så mycket man ska tänka på.
Ja.
Och då tänkte jag att mammas roll idag blir för att hon får hålla koll på klockan.
Vilken heder.
Då får du inte fuska, mamma.
Jag lovar. Ska inte göra det.
Och så hjälps vi åt allihopa som vanligt att hålla koll på om det kommer något tics. Eller hur?
Ja.
Känner du dig redo?
Ja, jag är redo.
Då tycker jag vi kör igång. Nu kan mamma starta klockan.
Vänta. Gör si, då ska jag göra. Gör si. Nej. Gör så, då ska jag göra. Gör si ska jag inte göra.
Ja, exakt.
Okej, ja, jag är redo.
Då kör jag igång.
Gör så. Gör så. Gör så. Gör si. Nej!
Okej.
Ja, vi
Men jag har
fortsätter.
inte tixat
Du har
än.
inte tixat en enda gång. Då fortsätter vi. Gör så. Gör så. Gör så. Gör så. Gör si.
Nej, jag tixade.
Kom det tics.
Ja, ögontics.
Superbra att du märkte det själv, Kim.
Hur många?
26 sekunder.
Ja, men det är ganska bra.
För att vara i den här leken. Superimponerande Kim.
Tack, mamma.
Exakt, för det har vi ju pratat om förut också. Där, att, men du klarar av att stoppa vissa tics, kanske en hel lektion i skolan. Men nu gör vi det ju extra svårt. Och då kan man ju ha en egen rekordlista för just det här. Som handlar om gör si, gör så. Och då vet vi ju nu att rekordet för det är 26 sekunder.
All right, thank you. We thank the ladies again for this presentation. And I mean, this is just an example of something you could potentially do with a patient. We're not saying now that you should go and play this game with every patient. And I mean, for some patients, this might be just distractive and they might not be able to focus on the practice while doing this. But keep a dialogue with each patient and see what do they think will actually increase their premonitory urges and what do they think will actually make their practice more difficult and what do they want to be able to do in their everyday life, and then practice on those things. And if the child is very unmotivated but there's still a clinical need for practicing this and suppressing tics, then perhaps luring them into doing the practice in in a game or something like that could be a way to go. So just an example. A little bit of troubleshooting now related to ERP practice. So if a tick is extra hard to suppress, usually what the manual instructs is that you switch over instead of I mean, what it means here is that the child practices to suppress all ticks at once, and then there's always the same tick coming, like blinking or something like that. So one way could be to just focus on that tick until the patient is able to suppress that tick for at least 5 minutes. That's kind of what the manual says. And then you can go back to suppressing all ticks at once. And also, if necessary, you could try adding a competing response as in HRT. I will talk a little bit more about this in a moment. But back to the eye ticks, for instance, it could be also that small ticks are hard to suppress. So one way could also be actually skip suppressing the smaller ticks altogether, especially if the patient doesn't even notice when she does them. So I mean, this could be added later, or if they're not actually impairing the child, the patient, it could actually, you could actually leave it aside. The most important thing is that the patient actively practice ERP, not whether she suppresses all ticks or if they might not be even aware of all the ticks. So, I mean, what we want the child or the adult patient to be able to do is to get the feeling and the learning outcome of actually feeling that they're able to do something and able to practice and succeed with the suppression. Not that they actually succeed in suppressing all ticks if there's ticks they might not even recognize, or if ticks they do not find significant or bothering enough. And that is also last thing, perhaps not the best translation here, but it's what I mean is if the patient does not if they're not bothered from the smaller ticks, there's perhaps no need to focus on them either. More troubleshooting. If the patient does not sense any of the premonitor urges, I mean, that might be a problem, one might think, because the whole treatment is kind of built, the rationale is kind of built around this. But this is fairly common in younger children, and it doesn't have to be a problem. What you could do potentially is actually work with awareness training, kind of like you do in habit reversal training. Play the game, capture the tick, which is that the therapist or the parent plays with the child, and the one who discovers the tick first gets a point, or gets to take a candy from the bowl or something like that. So it's kind of game who can spot the tick first, the patient or the therapist or parent. You could also ask the patient how it feels in the body at the place the tick is expressed. And another way could be like start expressing the ticks and stop halfway and ask the patient, do you feel anything now, or do you feel that you need to do this, and how does it feel? So another thing I think we discussed last time with the whole habituation thing, does the premonitor urges actually decrease? Or it could be that the premonitor urges or actually also the ticks do not decrease. So then you could switch on focusing rather on suppressing ticks in the situations that the patient primarily prefers, kind of perhaps in school or in other social situations. And you can also emphasize that it's good to have an increased control over the ticks, and even though the urge might not decrease and the ticks might seem to be the same, the patient might have experienced an increased control over ticks in their specified situations where they actually the most want to suppress the ticks. And potentially connected to treatment goals, if you had any specific goals, like to be able to do certain things. If they're able to do that, even though despite the ticks, if to put it that way, it might still be a treatment outcome of a value. Continue troubleshooting. The patient shows no tics during the sessions. I've now highlighted that it's so important to do the ERP practice during the sessions, and it's actually quite typical that you can hear the patient has a lot of perhaps vocal tics in like the waiting room, and when the patient comes into the session, there's like no tics, and it's just a situation like sitting in this formal situation. It's not that they're necessarily actively suppressing the tics. It's just a situation that makes it that that no tics come out. So what you can do then is try to provoke the tics, perhaps let the patient purposely do the tic movements, look in a mirror, imitate the tics, ask about premonitor urges, ask the patient to imagine a situation where she or he has many tics, physical activity, or go to a place where tics usually come. So try to provoke it in some way. It could also be that the patient comes and perhaps especially adult patients come and say, well, aha, so I'm supposed to suppress my tics. I've been doing that already for 30 years or something like that. And I mean, then you need to again explain the rationale and say that they might have a potential. I mean, be humble about it. I understand. I mean, this is what we can offer, and it is evidence based, but we can of course not promise anything in the individual case. But also say that there's potentially a different outcome when the practice is more structured and when exposure is included, so to make it intentionally more difficult. And you can also say that if necessary, this is not enough, we can try adding the competing responses as an HRT. There could also be some confusion among parents regarding when tics should be noticed and not. And I think I touched on this a little bit already, that general comments about tics, like kind of like nagging about that the child should stop doing the tics, that we want to avoid. But sharing, encouraging, and providing reminders linked to the treatment, that is kind of that is okay, and kind of also what we want them to be doing. It could also be good to provide some reasonable expectations from ERP, and what I say now is also goes for HRT actually. I mean, we don't want to kind of sink the treatment expectations totally, so they don't do anything in the treatment, but it's also good to not oversell the treatment, that this will take away all the tics when this will not be the case. So there's currently no treatment that can completely cure the diagnosis, obviously. I mean, ensure that the patient's tics go away completely. So inform the patient about what to reasonably expect from the treatment. And this could be increased control over the tics, that the patient can more easily control it in the situations where they have tics, most tics, or where they especially wants to be able to suppress their tics. I mean, we're hoping that the tics will be reduced. That's kind of what has been measured in the clinical trials. We kind of hope a little bit also that the premonitor urges will be reduced, but there's some uncertain data there. But what I would say is probably the most reasonable outcome is that the tic-related impairment will be reduced, because that might be reduced by various strategies and treatment ingredients, such as just normalizing the whole thing, the psychoeducation, working with ERP or HRT, and then also perhaps working with other functional analysis at the same time and such. I think working with this combined, many patients at least experience that the tic-related impairment is reduced. And I guess that's the most important thing anyway in all psychological interventions, that you want to be less impaired by your symptoms. I think we touched on this already a little bit last month, and there was a question about this, combining ERP and HRT, which is a very good question. And I'm sorry to say I don't have that. There's no good data on when to use ERP or when to use HRT. It has not been compared in a fully powered clinical trial, so we don't really know. But it is popular among therapists, especially in Europe, to combine the elements of ERP and HRT for the specific patient's individual needs. And that could be, for instance, I mean, HRT is then obviously using a competing response to help suppress a tic, and then doing that one tic at a time. So HRT could potentially be added to ERP if a patient is bothered by a large motor tic, which a competing response potentially could interrupt and be a successful aid for. So combining the two elements together. And this approach has been evaluated in a pilot study in Denmark with promising results. And here you see the reference for that. There's also a manual about this, which I think is in Danish. I'm not sure if they're going to translate it or not, but even I won't be able to read the Danish, I think. So, but I don't think you perhaps need a combined manual to be able to do this. If you know HRT and you know ERP, then of course you get an idea of how these can be combined for the individual patient. So that's kind of what the last point is. With increased clinical experience in a patient group, you might see benefits in combining various elements of the treatments, since they're quite similar to begin with. Both are about tick suppression and both include focusing on a premonitory urge. But be sure to know what you're doing, though. I mean, it's always safer to stick to an evaluated protocol if you're new to this. Now moving on to functional analysis, and this is something that can be added to ERP or can be added to HRP. It could potentially be used as a standalone intervention as well. I doubt that it will be super effective just as a standalone intervention. But what I will be talking about now is not actually very specific to tic disorders. It could be used to any diagnosis, more or less, that is typically treated with functional analysis. So it's more or typically treated with behavior therapists. So it's more like to actually do a function analysis and see what is kind of reinforcing the symptoms, and then try to change this in a way so they're not as reinforced as they are now. And now we're trying to do this with kind of a semi-neurological symptom here, so which is just semi-voluntary. So you need to have some reasonable expectations also here how effective this will be. But added on in this package with HRT or ERP, and it is a part of the package called CBIT, Comprehensive Behavioral Intervention for Tics, which includes HRT, functional analysis and interventions, and relaxation training. So it is used in that package. So I think it adds something, at least in together with the other strategies. So the first slide here, examining which situations the tics occur the most, what times, what places, during which activities, with which people, and when feeling which emotions. And then you can write it like this. I know there's various traditions. Some are used to like ABC, antecedent, behavior, consequences. Here I have more like situation, behavior, and then split the consequences into short-term and long-term. But I mean, you could use whatever really. And the example here, so Friday the 24th of May, at home at the dinner table, tired after a long day at school. So the behavior, many motor tics such as facial grimacing, shoulder shrugging, and arm movements. Short-term consequence here, the parents say that the child or the patient has to leave the table, escapes. So the child kind of escapes the situation, and the tics decrease in the moment because they escape this situation. And the long-term consequence here might be that the tics are at risk to increase or continue at the next family dinner, and it could also be other secondary consequences, like the child does not eat enough and then gets tired and hungry, and then there's a risk for more tics due to the tiredness and hunger and such. So this is just an example. I'm not saying that this will work like this for every patient. That's the charm with functional analysis. You need to do a functional analysis with the specific patient to know what might reinforce their behavior in question. I think we talked about this already, the basic rule, which kind of relates to this kind of like functional analysis as well. We don't want a certain reaction from other people, from family and friends and teachers. And so if avoidable, do not openly pay attention to or comment on the tics. Such attention may increase the frequency and intensity of the tics. So family should not comment, nag, or tell the patient to stop performing the tics. If the patient could, he would of course already have stopped. So, I mean, if the patient could just suppress all tics at once, they would already have done it, of course. And if the patient himself wants to talk about the tics, then it's okay. Instead, the family should instead focus on reminding the patient to use strategies from the treatment, but not so frequently that it becomes annoying. I think we've discussed this already. Here are a few examples of some functional interventions connected to the functional analysis. And these are just examples. I mean, you need to do an individual analysis for each patient in question. So here then, here's the first example. There's a lesson in school. So a possibility to take a break if tics are increased during a lesson in school. So there's a possibility to take a break. Think about the seating in the classroom. If there's a lot of vocal tics, perhaps it's good to sit in the front, because then the peers does not hear them as easily. Or if you have a lot of vocal tics, perhaps good to sit in the back, because then the tics are not as visible by other peers. Could also be informing classmates and teachers about the tics, normalizing the whole behavior. Screen usage, if that is something that seems to be increasing tics, then of course try to see if it's possible to reduce screen time, perhaps do physical activities prior to screen usage. But note that it's not always desirable to remove all the fun activities. That could perhaps be like punishing the child for having tics. So we remove all the fun activities where they have a lot of tics. Remember also that being excited is an emotion that might increase tics. So we don't want to remove that. But if there's something that is reasonable to change, it could of course be tried. If homework is a situation that increases tics, then perhaps they could be divided. Work with a schedule perhaps, so there's not a lot of discussion before, and do the homework when the patient is most alert, have many breaks, sit in a certain place, help out with the homework. If there's increased tics at the dinner table, perhaps eat early dinner, tell siblings not to comment or tease. Or if there's an increase when getting out of the house in the morning, perhaps write down a morning routine, prepare clothes and pack the bag the night before, try to have plenty of time in the morning. I mean, this goes for other conditions as well as working with ADHD or autism. It's just trying to reduce stress more or less, and stress might increase tics. So same with working with a bedtime routine, perhaps go to bed earlier, calm activities prior to bedtime, listen to calm music, massage, evening walk. And then again, if it might be that when they're being with friends and the patient gets a little excited, this might be a situation where we do not necessarily take action, because we don't want to prevent the patient from doing fun stuff. But however, this might be a situation where there is a good opportunity to use the ERP strategies and suppress the tics and such. And in general, stress and fatigue might tend to increase the tics. So trying to reduce stress and fatigue can be beneficial to the patient. And these are more some specific situations which are described also in detail in this, the manual I will show soon, the CBIT manual, HRT CBIT manual. And that is that we don't want the patient to avoid or escape from tasks by doing tics, because they do not need to do house chores, or do not need to do homework, or do not attend activities. There's a risk here that we do the patient a disservice. We want the patient, they should not be able to escape things because of the tics, but I mean, you can help out so the conditions are as optimal as possible for the patient. But we don't want to kind of reinforce the tics by taking away like things the child does not find very fun doing. Could be like a vicious cycle there. And the same, we don't want to give comfort and calm the patient in direct response to the tics all the time. This could also perhaps reinforce, so the child kind of not consciously perhaps know, but they kind of, it might the child might be unaware of it, but it might be that when the child tics, they get very nice comfort from the parents, and this might perhaps be reinforcing the tics. So we want the family to, instead of focusing on providing positive attention regardless of tics. So I mean, it's better to do this in various situations and not just during the tics. Now we're approaching the questions. Oh, so it's just a summary then. We talked today about a suggested session by session content. The session should primarily include ERP practice, and a suggestion is to vary the ERP practice to make it more fun. There were several examples of how to troubleshoot, and we talked a little bit about combining ERP with HRT. It could be helpful in some cases. And then you could potentially help could be to add function analysis and interventions to the ERP or to a HRT. And then, of course, the basic rule that family, etc., should not comment on the tics. Here are the two manuals again. The one to the left is the HRT CBIT manual available, and the one to the right includes information on HRT and ERP. All right, now you're very welcome to post your questions in the chat. We have around 9 minutes left here. Let's see if there's anyone's already.
In the meantime, Per, thank you very much. I'll just launch the post webinar evaluation.
Crystal clear, everything about HRT, ERP, and perhaps HRT as well.
I have a question, Per.
All right.
I was wondering, what is the youngest child you've ever worked with ERP? And, what are your tricks for working with very young children?
I think in one of our studies, we had from 8 years and up. At the clinic, perhaps I think 7, 8 years or so. In my experience, below 7 years, the patients themselves the tics are usually not very severe.
Yes.
And the patients themselves are not very aware of it and not very motivated to work with it and not very bothered by it.
Yeah,
so it
exactly.
kind of becomes pretty natural to not work with younger children, and that more perhaps provide information to parents about perhaps the function analysis part and the psychoeducative part, of course.
Mm-hmm.
And focus more on that. And I think there is a paper from the American group on where they use CBIT for the younger group from 5, 6 years or something like that. It's a pilot study. And what I remember from reading that paper was that they focused more on the function analysis part and less on the HRT part because of the age of the child, and perhaps the child being less aware of the symptoms and perhaps less bothered as well.
Yes. Thank
We
you.
do have a question there, Per,
All right.
from Joanne Park in chat.
Thanks for this very helpful presentation. For ERP for OCD, the goal is to reduce all compulsions to decrease OCD-related symptoms and impairment. Does the same go for tics, or is it okay for patients to suppress tics when it matters for them and then release suppression? It's a very good question, and there's not enough data on this. I mean, clinically, it would be very difficult to force a patient to do it all the time, because this is tics is kind of different than OCD in a way that we know that the compulsions come in direct response to the obsessions, and we don't want to reinforce that connection. So we really want to expose for the obsessions, and we want to have the response prevention, obviously, for the compulsions. That is pretty clear, and I think everyone is. But also in OCD, it's difficult to kind of be able to get control all compulsions and such. I mean, you need to start working somewhere, and I think and it's perhaps not reasonable to always have an expectation and think that this treatment will be worthless if there's still some compulsions. I mean, the more modern way of looking to OCD treatment is also to perhaps allow a little bit of compulsions, if that's a step closer to increasing the level of the exposure, or to actually be able to start working with exposure at all. So I don't know really, but my clinical experience by working especially with children is that you need to allow a little bit and focus on when they think this is important for them to work with the suppression, and then just try to make them do this as much as possible in as many situations as possible to increase the possibility of it becoming automated and for them to generalize. Then it might actually be easier for them to do this also in the situations where they're not as motivated by it. And I think in the end, sitting with a patient, you can't really force them to do anything. And I think you will probably lose the patient quite quickly if you have like, okay, all the time at home when you have these tics, you need to work with them, even if you're just alone watching television. I don't think anyone will have any energy to do that really if they have severe tics. So I wouldn't say that then you will probably lose their motivation and they will just not come back after a few sessions. So you need to think a little bit smart around it as well. But if this at the same time makes like the long-term possibility of the treatment outcomes worse, it might be. I don't know. No one has really looked into that. Thank you, Joanne, for that. It's a very good question. So a question to everyone after these two sessions. Do you think that this introduction, has this been enough to feel comfortable on starting to work with ERP, and is this something you think you're interested in pursuing now with your patients? Would be interesting to hear your thoughts in the chat, perhaps, if you think this would be a possible treatment option for you in your everyday clinical life. Oh, Joanne writes, I'm doing ERP for a patient with tics after participating in your talks. Very nice to hear. Yes, I could see using this with clients, says Sarah. Thank you for that. All the best with your treatments and your sessions in the future.
Tack så mycket, Per. Jag vill bara säga det var en bra jobb. Tack så mycket.
Tack ska du ha. Someone talking Swedish here. Thank you for that. Where are you from, since you know Swedish?
I used to live in Stockholm. I went to Mid-Sweden University.
Okay, very, very nice to hear.
Yeah.
Thank you for your feedback.
Yeah, thank you.
All right, thank you for all the kind words in the chat. Any final questions before shutting down?
Shall we? No more questions at all? Okay, I'm just going to leave the post evaluation there for a while, and I'll just finish up. And it goes without saying, thank you so much, Per, for two truly excellent presentations, and certainly learned loads. And thank you very much indeed. Hopefully, you can come back again sometime and give another presentation.
I will be very happy to do that. So I'm very grateful that you invited me. It was really fun, I think, and also to see this great interest. A lot of people listening to this. So thank you very much.
Absolutely, thank you, and thank you for all who've attended. The next webinar in our series is on November the 17th, which is Trichotillomania Mania, Phenomenology, Assessment and Behavioural Treatment, presented by John Piacentini. Therefore, if you haven't done so, please go to our website, sign up, and get your friends to sign up. And thanks again, and we look forward to seeing you again at the next webinar.
Don't miss it. John is great.
Mm-hmm.
Thanks again, Per. It was really nice having you.
Thank you, tomorrow.
All right. Bye-bye, everyone.
Bye. Bye, Per. Thank you. As before, Per, I'll once I get the report back, I'll untangle it and I'll send it to you. It's
Yeah,
not
brilliant.
today, it'll be by tomorrow.
Was a question about the slides here, I think, but you will send that out, right?
Yeah, absolutely.
Perhaps.
Well, they'll be available on our website.
Yeah. So, any more questions or so? All settled, right? Julian?
Yeah, absolutely. I don't see any more questions there. Lots of gratitude, and I can only echo that.